As ma'am has already introduced me, so again a very good introduction has been given by ma'am. But the question remains, why should we talk about trauma? What is the need? What is so urgent to talk about trauma in the current scenario? Because there are many reasons behind that. First is there is no vaccine for trauma which can prevent you from getting injured. So there is no vaccine, and definitely there is no immunity. So everyone on this earth is supposed to have a trauma someday or other. So there is no immunity, no vaccination available. Other is very poor social awareness. We actually don't know if there is a trauma victim, how the victim has to be transferred and where it has to be transferred. Many people even don't bother because they think that if they will take care of a victim of trauma, they might get up in some trouble because of some medical legal issues or police issues. So they are very scared. They don't want to spend their time on that. Though the court and the government of India has very clearly stated the definition of good Samaritan, but then I don't know that whether we are aware of this or not. So people think that let's escape from the scene and let the victim suffer and police will take care. So why should I take care of this? Very important aspect about trauma is it is the preventable sort of death. Preventable in view of that if you take proper precautions, if you follow the road safety rules, maintain your vehicles, take proper precautions, and then if someone has suffered trauma and you are available nearby, it is your duty to give the care whatever you can provide to the victim. The very scary aspect of this scenario is that it is killing the bread earners of the family, who are mostly of the 15 to 45 years of age group, and by loss of this age of the life, it is a big psychological and social burden over our society. If we see the current scenario, the roads are flooded with the vehicles. Lot of automobile accidents, some minor, some major, are happening throughout the globe, every place. There is no place which is immune of these accidents happening. We are very much careless about our safety. Though the recent pandemic of the COVID-19 has given some sensitization regarding the use of masks, but we are not still careful about use of other safety things regarding road safety rules, like the use of a very basic thing, use of helmet while driving an automobile. So we are not aware of these things. We don't follow all these things. The youngsters, they are very fascinated about power bikes which are available nowadays, and they usually drive these vehicles at very high speed. New vehicles are available, very high speed driving is seen on the roads. Government is putting lot of focuses to improve the highways also. Lot of new expressways are coming up, but then there are clear cut instructions that what should be our speed limit on these roads, but then hardly we take care of all these things when we drive on the roads. Government is putting lot of focuses, lot of road awareness program, road safety instructions are being given from the government, but we hardly take care of all these things and we suffer trauma many a times. So now coming to the proper care of the trauma, first we talk about what is the chain of survival. So it starts with early access. How do we get early access? Recently Government of India has made the universal number 112 as the emergency number throughout the country, calling on which you can get an ambulance as soon as possible from any nearby place. Once ambulance is available there, it is supposed to be fully equipped with the paramedics and all the equipments, which should ensure to start an early cardiopulmonary resuscitation, so that the chances of recovery of this patient becomes very high. There is also focus to start defibrillation as early as possible, and probably all the ALS ambulances, they are equipped with defibrillators. So defibrillation should be given as early as possible, and this is actually the same chain of survival in not only in the trauma but all the emergency life-threatening conditions. So coming back to the trauma, it mainly involves two phases: pre-hospital care and the hospital care. And mind you that pre-hospital care is no less than a hospital care for a trauma patient, because the major killer in the trauma patients is this lethal triad, the triad of hypothermia, acidosis and coagulopathy. A patient of trauma bleeds a lot and remains hypothermic, and he is on the verge of developing acidosis and trauma-induced coagulopathy, which sets this lethal triad, and any of these entities once set in, it exacerbates the other and it makes the scenario worse. And then this lethal triad has to be prevented, because once patient has landed up in this lethal triad, there is very minimal chances of recovery thereafter. So what should be done in pre-hospital care? That can be done by anyone available at the scene of trauma, maybe a common person who is moving from there, or police personnel, or trauma ambulance workers. The important thing is that to prevent or to control the extremity hemorrhage, it can be controlled just by a direct pressure. A bleeding part can be pressed, and many a times the hemorrhage can be controlled very nicely. In the other cases, sometimes the patient suffers traumatic amputations and a lot of hemorrhage is happening from there. So the tourniquet should be applied, can be applied there, and hemorrhage can be stopped. But then the duration of this tourniquet should always be taken care and noted and taken care. Sometimes there are hemostatic topical dressings are available, or if they are not available in the ambulances, just by packing the bandage in the wound which is bleeding can many a time serve the purpose and stop the bleeding. Sometimes there is fracture of the long bones, maybe open or closed fracture, and then splintage has got a very important role. Any log available there at the scene of trauma, and if the ambulance is having this splints available, so this splintage works very nicely and gives a very nice relief to the patient. Sometimes patient has got the pelvic fracture. Pelvis is supplied with a lot of vascular network, so pelvic fracture has got a tendency to bleed a lot. So simple application of pelvic binder, and even if it is not available, just by using a bed sheet even or any cloth like that, just wrapping around the pelvis and keeping pelvis in position will help this patient a lot and can stop the hemorrhage in this patient. So talking about two very important entities in trauma, first is the mass casualty. Mass casualty, like there is a bomb blast, there is earthquake, rail accident, in which the number of victims is very high. So high that they are more than the capacity of the trauma center available nearby, and it is overburdened with these patients. So in this scenario, your focus should be to save as many as people possible. So you should prioritize patients on the scene of the trauma to transport those patients to the hospital. And then again in the hospital, they should be prioritized that which patient should be given care at first, so that the maximum number of victims can be saved. On the other hand, there is multiple casualty, in which number of the persons injured may be high, but they are not beyond the capacity of the management of the local trauma center, and they can be managed nicely. And in this scenario, the focus should be to save all the patients which are coming to a trauma facility. Now, very important entity in the trauma is the golden hour. It is not actually the hour even, but it is the time following the traumatic injury when a prompt medical treatment has the highest likelihood to prevent the death. So it should be given as early as possible, and it is said the initial 60 minutes are very crucial for the patient. So if a proper care is received by the victim in the initial first hour, the chances of recovery becomes high. Recently, the term platinum 10 minutes has been introduced, that initial 10 minutes are very vital in seriously injured patients, and if the proper care is given in initial 10 minutes, the chances becomes very high even in the seriously injured patients. So the golden rules in the pre-hospital phase are: stabilize the neck first. Many a times at the scene of trauma, the people are available and they're not aware of this entity, that they have to take care of the cervical spine, and neck remains unmanaged, and patient is carried without stabilizing the neck. The cervical injuries are very common in the trauma patients, and rather it is said that a patient of trauma should be supposed to have a cervical injury until proved otherwise. So all the trauma patients, neck stabilization is mandatory and should always be taken care even in the pre-hospital phase. The other thing is that trauma is a teamwork. It is not like that you stay at the place of the trauma and keep on doing whatever you can do and you lose the patient. Rather, the concept is You scoop and go. You take patient to the, call the ambulance, take patient to the ambulance, keep on doing the resuscitation during the transfer, whatever you can do to the best of your capacity, and transport that patient to the trauma center so that the chances of recovery of this victim may be high. So coming in the hospital phase, the important aspect is triage, as I have talked about in the mass casualties also, that triage is a concept actually which prioritizes the patients depending upon the needs. So a patient who is more serious should be taken care first, rather than a patient who is less serious, or sometimes the patient is lost, that hardly requires any attention. So the color coding system has been devised, in which the red color code means the patient is very seriously injured, very seriously ill, and should be taken care as early as possible, otherwise the patient will be lost. The next category is the yellow category, in which the patients are very serious, but not that serious as the red category are. But then if the proper care is not given within time, they will turn up into the red category. The other category is the green category of the patient. They are the walking wounded patient having some sort of fractures in the limbs, and these patients, in fact, they are the assets in the cases of the mass casualty. In mass casualty, the number of victims are very high, so they can be utilized in managing the patients who are seriously ill. At least they can make some record, and they can help other patients to go to the ambulance, and they can call facilities to take care of the seriously injured patient. So they can be involved in the mass casualties. Otherwise, they are stable patients, and they can wait for some times by the time red and yellow category are being managed. And the black color code means the patient has already died, so there is no need to waste any resource in this patient. Now, talking about the proper trauma care, like all the emergency life-threatening situations, it starts like A, B, C, D, E approach. This is what we call as primary survey and the adjuncts, in which A means the management of airway, which always goes in trauma with the cervical spine protection. Next is the breathing. Breathing goes with the ventilatory support. Next is the circulation with the control of the hemorrhage. Next is the disability control, which goes with the neurological evaluation. And last is the exposure and environmental control, which has got a very integral part to control to prevent the hypothermia, because once hypothermia is there, it will have the tendency to kill this patient. And the motto is you keep on assessing A, B, C, D, E, and you take actions to correct those things and or anticipate any further damage, and then you reassess. Like if you have assessed the A and you have found anything which is problematic with A, immediately manage that. Again, confirm that it has been managed. Once you are sure that it has been managed, then only move to the B, because that's why it has been prioritized like that. It is not like that you keep on assessing A, B, C, D, E and then come back to A and then start management of A. It is like assess A, any problem, correct A, reassess, be sure that A has been managed, then only move to the B. But if you have got a team, you can decide that which member is managing A, which member is managing B. Things can be done simultaneously. Otherwise, the priorities are like A, B, C, D, E. So talking about A, as I have told, it always goes with the protection of the cervical spine. The questions you can ask with you is, does this patient has an adequate airway that they can protect? This is a very important question that you should ask yourself, and you should try to get the answer of this question, because your aim is to get a patent and protected airway. The patients who are having the injuries over face and neck, they are having high risk of airway, the injuries in the airway, and they should be specifically taken care of. Though the trauma is always mostly the multisystemic involvement, no organ system is escaped. Sometimes patient having loss of consciousness, having traumatic brain injury, they also have airway at risk. But by and large, patients who are having injuries over face and neck, they are definitely having some compromise in the airway and should be specifically taken care. So how you assess? You will first look if there is facial trauma, any foreign body or ill-fitting loose denture which is blocking the airway. There might be some secretions which are blocking the airway. Then you can find some sounds like stridor present there. You can feel an expanding neck hematoma, And a very important aspect is that, is patient talking to you? If patient is talking to you normally, it means definitely airway is going to be patent in this patient and protected as well. So again, you have to identify whether airway is patent. If not patent, whether it is obstructed by secretions or by some foreign body, or there is acute loss of consciousness. Sometimes patient has got traumatic brain injury and has got the Glasgow Coma scale less than 8, and this patient has got a very risky airway, and in this patient the airway should always be protected as soon as possible. So like this patient having facial injuries, they are definitely going to have some airway compromise. There is no question about that. They are going to have airway compromise, and in these patients you should try to make airway patent by removing any secretion or any foreign body, and you have to make it protected by using endotracheal tube. So first maneuver what you can do is just open up the airway by doing chin lift maneuver. This jaw thrust maneuver is not done in trauma setting because it involves the movement at the neck, so it is not recommended in the trauma setting. Chin lift is done. You just lift the chin and open up the airway. That can solve sometimes the purpose. Then if you have found something which is blocking the airway, just suck it out. If there is any foreign body, just remove it. Sometimes patient is drowsy and you can just insert an oral or nasal airway, which will solve the purpose. So this is how a chin lift is done. Jaw thrust, as it involves the movement at the neck joint, so it is not recommended in the trauma setting. These are airway devices. First is this direct laryngoscope. So whenever you are on duty in the trauma setting, you must always find that these equipments are available with you and they are working properly. Sometimes you might get a patient in a hassle and you find that there is no battery in this laryngoscope because there is a bulb which glows only if battery is available. So the battery has burnt out and you have not checked it, and you just become panicked in that scenario. So you should always check that you have got a proper size of the tube available with you. All these equipments are available and they are working. They should be properly checked whenever you are having a duty, specifically in the trauma setting, but virtually in all the emergency scenarios. This is the oropharyngeal airway, the length of which is measured from the angle of the mouth of the patient to the angle of the mandible. This is the length of the blade, and this airway can be can be selected for a patient. So you have to find out if there is need to put the definite airway. This can be done by intubation, endotracheal intubation, which can be achieved by either by the oral route or sometimes by the nasal route. But non-anesthetists should always try the oral route because this requires a bit specialization. You can always go ahead with rapid sequence intubation rather than using drug-assisted intubation. And if you are not able to do all these things, you can go ahead by doing the surgical cricothyroidotomy and achieve a definite airway in this patient. The important thing with the airway is that if you think that airway is compromised and you have to put a definite airway, just do it without waiting for anything, because by the time you wait and you decide and you consult, you can lose the patient. So it should be done as early as possible. Always assume the cervical spine is injured in patients of multisystemic trauma, patients who are having acute loss of consciousness, and any injury which is above the level of clavicle, or virtually the rule of thumb is that cervical spine injury should be assumed in any patient of trauma until proved otherwise. So always take care of cervical spine. This is the bottom line. You can do it by cervical collars which are available mostly in all hospitals and trauma centers. They are also available in the ALS ambulances, or if collar is not available, sandbag is available which can give support to the cervical spine. But the better is to use cervical collar, and long spine board is important for a patient who is supposed to have the trauma and some spine injury. If you are not available in having any of these things, you should know how to give manual inline stabilization to this patient. This is also important during all the procedures being done, like intubation, like putting the cervical collar, this maintenance of manual inline stabilization. Like you see that this is cervical collar is being applied and this person is holding the neck of the patient so that it may not move while applying the cervical collar. Again, you see this is the long spine board on which this patient is being fixed, and the neck is being fixed so that there should not be any movement over the neck joint. This is how manual inline stabilization is given. See, notice the hand of this person. This is going beneath the shoulder and taking care of the shoulder and the neck as well, so that there should not be any movement over the neck joint while putting this cervical collar in position. Again, a very important thing is that sometimes these victims are fortunately having helmet and you have to remove these helmets. So again, during removal of the helmet, see the hands of this person. This is stabilizing the neck while removing the helmet, and there should not be any movement over the neck joint. Again, this person has taken over the prevention of the movement at the neck joint, and this is what is called as manual inline stabilization of the cervical spine. So coming back, the question in airway should be answered again and again, that whether airway is patent and whether it is protected or not. And if these questions are answered, then only you move to the B, which includes the breathing and the ventilation. Because the patent airway does not ensure the proper ventilation. Mostly the patients who are having the injuries over the neck and the chest, they are supposed to have some problem with the breathing, because for the good gases exchange, oxygen should go in and CO2 should go out. So assessment of breathing can be done just by looking at the chest movement and the tracheal deviation. You can listen, you can auscultate for the presence or the absence of the breath sounds. You can feel the chest expansion also. You can feel the air movement, and you can percuss the dullness to find out whether breathing is okay or not. The important scenarios are tension pneumothorax, which is the dire emergency condition, and in this scenario you need to intervene as early as possible. The other important serious injuries are flail chest, in which the multiple ribs are fractured at multiple places. There can be massive hemothorax. Sometimes there is open pneumothorax. There is a chest wall injury and the chest wall is open to the air. This is called as open pneumothorax. So if you see this is X-ray, large amount of air is entrapped inside the pleural cavity, and rather it is pushing the trachea on the other side. So this is an X-ray of the tension pneumothorax. Rather, there is saying that if you suspect the tension pneumothorax in a patient, you should not subject even this patient for an X-ray, because if you have suspected tension pneumothorax in a patient, immediately take a white bore needle, put this in the fifth intercostal space in the mid-axillary line, and it will relieve the patient very significantly by the time you are subjecting this patient for X-ray or other investigation. So just putting a needle will help this patient and will save the life of this patient. Again, this is an X-ray of pneumothorax in which the air can be seen to be entrapped here. This is again a collection, and some collection is there, might be hemothorax. So how to manage the breathing? The first and foremost important is the attachment of the oxygen to the patient. You can give oxygen with the nasal cannula or using the non-rebreather mask, depending upon the need of the patient. Sometimes if patient is not improving on this event, you can use the bag and mask ventilation, or in the other cases you can even intubate the patient. To check whether patient is doing good, you should always attach the pulse oximeter and check whether the oxygen saturation is adequate or not. For the management of breathing, or if there is pneumothorax, hemothorax, you might not need to do needle or tube thoracotomy in these patients. So once this B has been managed and checked, you come to the C, which means the circulation with hemorrhage control. This is again very important aspect, because this is one of the most predominant causes for post-injury deaths that are preventable in the hospital setting. So patient has initially been managed and they died later because of torrential hemorrhage. Because hypotension is due to hypovolemia, which is due to blood loss. It should be assumed until you prove otherwise, because spinal shock is not that common as the hypotension because of hypovolemia, because of hemorrhage in trauma patients. So how you should assess the circulation? First, assess the level of consciousness. A patient who is drowsy, not responding nicely, not moving at all, he is supposed to have some sort of hypotension. And if it is a patient of trauma, you should always suspect that patient is having a significant amount of hemorrhage. Then you can see the skin color. If the skin is pale, so patient is cold, then again patient might be having hemorrhagic shock. Then you can assess the pulse, the rate of the pulse and the quality of pulse. because patient might be tachycardic in the initial sort of hemorrhages, and then in the significant hemorrhages, pulse might be feeble and may not be palpable at all, and sometimes you may not be able to record the blood pressure of the patient. That will give you idea that patient has got circulatory issues. So the aspects which are related with the hemorrhage control are: first is the early identification that patient is having significant hemorrhage. Sometimes damage control is required, because if you are not able to manage this patient in this setting, you need to shift immediately this patient to the operation theatre, and you have to control the hemorrhage surgically. Early management is always recommended, because it will prevent patient to land up in coagulopathy and development of the lethal TRAD, as we have discussed earlier also. This is ATLS based assessment of the shock, and this shows the classes of hemorrhage. The important thing which I want to emphasize here is that if you think about the class 1 and 2 hemorrhages, in which the patient has lost up to 30% of blood volume, in these patients there will be some sort of tachycardia, pulse rate will be a bit higher, but blood pressure will largely be maintained. So patient will not be hypotensive in these settings, up to 30% of blood loss. But once the patient has lost more than 30 to 40% of blood volume, then patient will have hypotension, and tachycardia will also be there. So it means that if you are having a trauma patient who has come to you in hypotension, means he has lost minimum 30% of the blood volume, and in these patients you should seriously think to give blood in spite of giving just fluids. Where from the patient is bleeding, if you have to consider, there is a mnemonic which says that 1 on the floor and 4 more. 1 on the floor means that patient might have an external hemorrhage. 4 more is one can be, if there is no external hemorrhage, the patient might be bleeding in the chest, or might be bleeding in the abdomen or retroperitoneum. Sometimes there can be pelvic hemorrhage, and sometimes there can just be fracture of the femur, like fracture of any long bone, which has blood a lot, and patient has got developed the hypotension. So if any patient or trauma patient has come to you in shock, you have to assess where from the patient is bleeding, and thereafter you can plan how to control that hemorrhage. So one can be external hemorrhage, and other 4 causes can be inside. So you have to find out and try to control this hemorrhage as early as possible. If there is external hemorrhage, you can always apply the direct pressure, if that can control many a times. Tourniquets are usually not recommended except you are planning amputation for the patients. And then fluid resuscitation should be started. You should use large bore IV cannulas, and then start the crystalloid infusion. Immediately you should subject patient for all the required blood investigation. A warmed ringer lactate is the fluid of choice. Fluid should always be kept warm in the trauma setting so as to give the patient as early as possible. It is not like that once patient has come to you and then you start warming the fluid. Then there is aspect of damage control resuscitation in the patients who are not recovering by fluid and blood transfusion. You should always assess for giving the damage control resuscitation to the patient. Earliest transfusion is recommended in all these patients, and sometimes if the number of transfusions is very high, you have to give in 1:1:1 ratio of the FFP, packed cell and the platelets. So this is recommended in massive transfusion. And in studies it has been proven that use of tranexamic acid improves the patient if it is used early in the trauma patients. So if there is extremity hemorrhage and there is open wound, you can pack and dress these wounds. You can find that if there are hard signs of the vascular trauma, earliest stabilization of the fractures should be done in cases of open wounds. Then if the wound is closed, you should try to find the hard and soft signs of vascular trauma, and fracture stabilization should be achieved as early as possible. Sometimes there is need to do vascular damage control, a major vessel which is bleeding and you are not able to control. In those cases, just putting the intravascular shunt, temporary intravascular shunts can help these patients and can help in the resuscitation of these patients. Sometimes there is thoracic hemorrhage. If there is minor hemorrhage, you can just place the ICD and patient might improve a lot. Then there can be extended fast which is needed. I'll be discussing later what is extended fast. And in the cases which are not being controlled by the initial maneuvers, you might need to do an emergency department thoracotomy to control the hemorrhage from the thoracic cavity. Then coming to the pelvic fractures, the pelvic fractures are usually not manageable by other means, and there is a very good role of hybrid OTs and use of interventional radiologies by embolization of these bleedings which are happening from the pelvis. If you see, there is contrast extravasation here which can be appreciated in this angiography, and the coiling has been done and the bleeding has stopped and patient has recovered. So the role of interventional radiology is very good, specifically in the pelvic fractures. Now talking briefly about the FAST, this means the focused abdominal sonography for trauma. The trauma patients cannot undergo formal ultrasound, so for trauma patient the FAST is very valuable. The role of FAST is to just find out if there is any collection in the area of concern. It will not give you that what type of collection this is, but in a trauma setting it is bound to be blood until proved otherwise. So first is the subgyphoid view, in which you see if there is any pericardial collection. There is the right upper quadrant view, which shows any collection in the Morrison's pouch on the right side, and the left upper quadrant view if there is any collection on the left side, and then any collection in the pouch of Douglas. Putting the probe just suprapubic region, you can find any collection in the pouch of Douglas. So if any collection, that should be blood in a trauma patient. About extended FAST, this includes two other views in which two longitudinal views are taken to find out whether there is any hemothorax. So if there is any collection in the pleural cavity, it can be diagnosed on the extended FAST. So this is the subgyphoid view. This is the pericardium which can be seen, and if there is any collection you can find it out. This is the right upper quadrant view. This is the Morrison's pouch. This is kidney and liver. If there is any collection between the kidney and liver, you can appreciate this. This is liver and this is kidney. So if there is any collection, you can easily appreciate like this. There is a collection here. This is the left upper quadrant view. See that this is spleen and there is collection. This is kidney and there is collection. There is collection again. So if there is collection, it is bound to be blood. This is the pouch of Douglas, and you see that this is collection here in the pouch of Douglas, and this is going to be blood in the trauma patients. So this is how you can assess C. You can take measures to correct C, and then you move to the D, which involves the control of the disability and neurological evaluation. There is a dictum in the trauma that you should not harm the patient further. You should receive the patient, try to do best you can do, but you should always prevent the further damage to the patient. The objective of this assessment is to establish a baseline level, like the level in which you have received the patient, and you can always assess whether patient is improving or patient is deteriorating with the time. So how you assess? A very simple tool is just by AVPU things. A means whether he is alert or not. P means whether patient is responding to verbal stimuli or not. If not, then whether patient is responding to painful stimuli or not. And U means patient is totally unresponsive to all sort of stimuli and not responding at all. You may use Glasgow Coma scale, which requires bit of specialization, and paramedics can do that. A common person cannot do this. You can check for the pupil whether they are reactive or not, and you can note it down. Then you have to find out what are the causes of loss of or decreased consciousness. This can be hypoxia in a patient who has got the chest injury or brain injury. Hypoxia can be a very important cause. Sometimes there can be hypoperfusion also, which has caused the loss of consciousness to the patient. Then direct trauma to the brain, traumatic brain injury might be a cause. Sometimes if there are no causes, patient might be under the effect of alcohol or intoxicated, and that can be a very important cause of loss of consciousness. So how to manage? You give proper oxygenation and maintain the perfusion. You should prevent further damage to the patient, and you should log roll the patient. Log rolling means you move the patient. 3 or 4 persons are needed in log roll, and you move patient as a whole, as a unit, to find out if there are any occult injuries, so that there should not be any further disability. After this, there is E, which means the exposure or the environmental control, because you cannot afford to have any surprises in the trauma patient. Like you started managing A, B and C. There is a wound on the back which you have not noticed. An open wound is on the back which you have noticed after 3-4 days. So you have to check patient all around, and there should not be any surprises. You should totally undress the patient, but simultaneously you should try your best to maintain the temperature so that patient might not develop the hypothermia. So hypothermia should be prevented. You might be feeling hot while working in the emergency, but you should always try your best to maintain prevent the hypothermia in the patient. For that, you should use the warm IV fluid. You can use blankets. Sometimes blowers are available inside the emergency department, and you should use all these things. So there should be quick distal neurovascular checkup to find out what is the level at the time of presentation, and relocate only if the patient is pulseless. So this is about the general population management of ABCDE. There are some specifics sort of patients which sometimes may present to you, like pediatric population. In pediatric population, approaches are same, priorities are same like ABCDE. Only the thing is that the amount of fluid which is required and the medications you are giving to these population will be having less doses, and you should know all what doses should be used. And the equipments which you need to use, like the laryngoscope, like the ET tube, they will be having a different size rather than you in adult population. Very important consideration sometimes in the pregnant female. Though the priorities and approaches are definitely same, but you should take care in the mind that anatomical and physiological changes are there during pregnancy, and you should be well aware of those things while managing these patients. And always you should keep in mind that you are handling 2 patients simultaneously rather than only 1 patient. Then the specific population is the elderly population, because this population has got a diminished physiological reserve. They might be having a lot of comorbidities in form of heart diseases, diabetes, COPD. So they might be presented in the patient, and they might be taking a lot of medications also, which may alter the responses as compared to a normal person. Like a patient who is on beta blocker will not have a tachycardia to start with. And if you are thinking that patient should have tachycardia if patient has got the hemorrhage, tachycardia will not be present in the patient who is on beta blocker. And there will be an error in the judgment if you are not aware of this thing. So this population has got the increased risk of death for any given injury as compared to the younger patient. So you should be very cautious while handling a geriatric patient. The last thing, and not a very important thing, is that the documentation. We many a time remain in hassle and we forget to document the things properly. The full details of the patient, time of presence, the presentation in the emergency, the scene of the accident, when has the accident occurred, these all things should always be noted, because most of these trauma patients, they are going to be medico legal cases, and you might need to go in court of law to give your evidence. And then in these cases, the documentation becomes very vital. You should always record what were the baseline vital signs, what medications you have given, and which dose, routes, and what was you have followed, and what was the response of that medications you have given. Then assessments being done, interventions, and what were the outcome is very important. So to document in all these patients. So talking about trauma training, then who should undergo trauma training? This is very important, as I have already told that no one on this earth is immune to the trauma. So the training should go to the common public even. They must know the basics of trauma management, how to transport at least to the patients, how to call ambulance, how to manage these patients before the ambulance comes. This should be known even to the common public. Then the police, which comes to the scene at first. So the police should be well aware that how the patient has to be transported and what precautions they have to take. Paramedics which are present in the ambulance should be fully equipped and should be knowing all the steps of resuscitation which they have to offer during transportation. And then medical staffs are should be trained for the trauma management. Training programs are there in the country, like one is the Advanced Trauma Life Support course. These ATLS centers are available throughout the countries. in which the medical personals and the paramedics like nursing staff, they are being trained. The centers are available throughout the country and the trainings are being provided on the calendar basis. You can easily approach and join and attend these courses. And the recommendation should be that these courses should be attended in the early part of career. Like a medical graduate who is just completing the graduation level, before he finishes the MBBS even, the training should be given for the management of trauma. And virtually all the medical graduates and all paramedics should be trained for the trauma management. Last thing is that team approach in the trauma, because trauma is not one man show. It is always a team approach, and that a good team is a must to ensure the trauma care, in which there should be a team leader who is present there all the time and giving instruction all the teammates then that how they have to do the things. And these teammates are required to talk back to the team leader. They're not allowed to talk there in between with the other teammates. Whatever they have to tell, they have to tell to the team leader, and then team leader has to instruct properly that what rectification or what further has to be done. And that is the very important thing to ensure the trauma care. Thank you.